to doctors. People thought I had asthma. Other people just didn't know. Someone told me maybe I should see a psychologist. I started experiencing symptoms of Sjogren's syndrome in my early 20s. They mostly presented as fatigue, inexplicable fatigue. But not just like, oh, I'm tired, I had a long day. Like, no end point when you live with a chronic condition. If you accept it, then you're also less afraid. This is what you have, but you don't have to let it take over your life. Of course, doctors really have to look at the whole picture. For example, Sjogren's syndrome affects more women than men, but you can't look at a person's gender and then treat them differently as a patient because of their gender. And that is absolutely something that does exist. My hope for the future of women and equality in the health industry is that no woman will have to go in and think that they're going to have to fight harder or advocate harder for their health or for their mother's health, sister's health, their daughter's health, or even that men won't have to feel like that they have to do that for their family members because they're a woman.
Good evening, and thank you for joining the Healthy Heart Nation's heart-to-heart discussion around the invisible woman, Black women advocacy. Half of white medical trainees believe such myths as Black people have thicker skin or less sensitive nerves endings than white people. An expert has looked at how false notions and hidden biases fuel inadequate treatment of minorities' pain. What's more, false ideas about Black people's experience of pain can lead to worrisome treatment disparities. In the 2016 study, for example, trainees who believe that Black people are not as sensitive to pain as white people were less likely to treat Black people for their pain. Well, tonight we're going to have the final of our 4-part series on Black women and health advocacy. And tonight I am joined by my co-host, Michelle Burrows from Black Facts. Welcome, Michelle. Thank you so much for joining us tonight.
Absolutely. Thank you for having me.
Discussion. And we are also joined by Dr. Nalo Hamilton, who has been with us this whole week to kind of take us through the health advocacies and the issues that a lot of Black women face when dealing with healthcare as it relates to the questions that we may ask or need to ask, information we need to know, and how we go about that. And I would like to say that this whole series was Nalo's idea, and Michelle had the series, the interest. Yes. In terms of addressing today's, so we're going to combine everything and hopefully everyone will get what they need out of these sessions. But Nalo, do you mind giving us a quick introduction of yourself?
Good evening, everyone. I'm glad to have this conversation. We have been ramping up to this conversation all week. I'm excited because it brings all the pieces of me together, my research background, my clinical background, as well as the fact that I'm a Black woman. So I am looking forward to this evening's discussion.
Thank you very much. And we also have a special guest, and her name is Dr. Lori Nelson. So Lori, can you give us a quick introduction of yourself and especially what you do as it relates to pain?
Hi, thank you for inviting me. My name is Lori Nelson, and I'm a physical medicine and rehabilitation specialist with training in interventional spine and pain medicine. So my practice is predominantly outpatient, and I deal with musculoskeletal, non-surgical musculoskeletal issues. So I see a lot of pain patients.
Fantastic. Thank you so much. Well, we're going to go ahead and start the conversation. And so, Michelle, I know you have some questions that you wanted to ask our guests.
Yeah. So tonight, since we're talking about women experiencing and how they're navigating racial and gender biases in the healthcare system, I wanted to ask both of you, let's start off kind of talking about how you as Black women, let's take the titles, you present as a Black woman. How do you or have you experienced gender or racial biases when you've accessed healthcare?
Yes, absolutely. And from both sides actually. As a physician, sometimes I'm doubted as a physician. If I walk in the patient's room, patients are like, okay, well, when is the doctor coming in? And then as a patient, when you're in the gown, they don't see your title. They don't see you're just another Black woman accessing healthcare. So, yeah, I've seen that frequently, where my issues, I've seen that with my family members when they've been sick or ill. And, we've talked about after the encounter, like, that was not handled appropriately. And unfortunately, sometimes you have to drop the doctor name, like I'm Dr. Nelson, so that patients will treat you or providers will treat you the way everyone should be treated.
Right.
Even in the healthcare system. So absolutely.
I would have to say that I've experienced the same. It's very interesting because sometimes you don't also present as your age. And so when you come in, it's like, well, I have these questions. I like to discuss this, and people want to brush you off. It's like, oh, wait 1 second. I'm not finished. The other thing is similar with family members. If I have to go with them to an appointment, I try to play nice. So I sit there and I'm very quiet, and we go over the dialogue that you should have with your provider before you go in. And I realize how important it has been because I've gone with my grandmother to many of her appointments, and she's gotten better with coaching. But again, there's a cultural situation for the time that she engaged with medical care for her very first time versus what I have had to do. And I have to say, one time that I became very professional is when she actually had to go to the hospital, and it was around the time that she had actually had a collapsed lung. They needed to address that, and she was in pain. And so I'm trying to be, supportive. And I said, well, ring this bell for your nurse to come in. And so she had rung the bell, and the nurse came in, and she stated what she had to do. And she is waiting. And for some of us, when you're in an environment in which you're familiar, but it's not your environment, it's really hard to sit on your hands. It's you're supposed to sit there and okay, so you're trying to help them with positions. You're asking, hey, should I get you some water? When you're like, I already know how long this is going to take to get it done. So what's the problem?
Right.
And the nurse took too long from the time that she had last, because we also count time. We know how long the pain medicine is supposed to work. We know the half-life. We know when it should be dosed. So it's hard for us to sit on hands. And so she took a little while, and she rang it again. And the nurse's response was, well, I'll be there. I said, oh no. I got up and went to the nice little queue. And I said, I'm Dr. Hamilton. This person is my grandmother. When will she get her pain medicine? Oh, life changed ever since somebody could get there, get the meds. So it's unfortunate that you have to do that because, as Lori said, I shouldn't have to use my title.
Right.
But once you do drop that title, sometimes things change. Things pay attention. You get some things, but it is unfortunate because you want to tell your patients. I know when I had to start with my own patients, say, okay, this is how I'm going to coach you when you go, because I've been on both sides where I shouldn't have to. If I'm giving my patient this information, then I want my colleague to do the same. I don't want to hear them say, well, they didn't say this. They didn't do this. We've had that challenge. But yes, unfortunately, we're not always our best selves.
Yeah. And Michelle, I know that you kind of experienced something similar, and so have I. So did you want to share a little bit about your experience?
Sure. Going in, like you said, sometimes you don't present, or they don't know how old you are, and may not take you as serious as they should. Went in, I had an experience, and I've shared this before. Went in and I was experiencing hair loss, and significant, hair loss. And went in, saw my primary, and said, I'm experiencing hair loss. Okay, never examined my scalp, never really asked me, any detailed questions. And so I waited, and there's a lot of typing going on. Like, what are you typing? Because I haven't said anything. You haven't asked me any questions. So I proceeded to say, do you want to examine? Let me show you. And luckily I had taken pictures. So I, oh, no, I don't need to examine. And then just started telling me, well, maybe you're low in iron. Maybe you're this, this and that. Let's go get some lab work done. And I said, well, I would actually like to see a dermatologist. Oh, no, we're not going to do that. We're going to, we're going to do your blood work. I was just here. If you looked on my chart, I literally had just had my physical. So I was like, all the lab work has been done. I'm not, none of these things that you've stated. Can you please, I think I'm experiencing something else. Can you please, write me a referral to see the dermatologist? And it was the same thing, resistant, not wanting to go there. And so then I said, okay, well, I need to contact member services. And when there was a realization that I had some knowledge about my rights, then it was, oh, okay, well, I guess we can, make the referral. But it was a battle. And I thought to myself, wow, if I didn't have this information already, if I wasn't a health professional and I didn't know, what my rights were, I would have left that office because I already was kind of, just really upset. I'll be honest. I was just really upset and discouraged. But if I didn't have the wherewithal, like I said, and know my rights and continue to advocate for myself, I would not have been able to see the dermatologist and would not have received, the diagnosis that I received. But there's, so many women that I know, like you said, you've taken your grandmother. We've all been there with, someone that we love, or either heard a story after the fact, about negative experiences they've had accessing healthcare. And this topic is so passionate to me, not only because I'm a Black woman, but because, I know a lot of women that I believe have passed because, first of all, it took them forever to go and seek out, help because, we continue as women. We just go. We take care of everyone else. We make sure everyone, has their needs met, especially when it comes to healthcare. We will make all the appointments and then strongly encourage our folks, right? And we take them there to their appointments. But rarely will we do the same thing for ourselves. We'll have a pain on our side and go on for months, and just keep pushing through it until it's unbearable. And then, it may be, your appendix ruptures and you end up in the, right? Mm-hmm. It's usually those types of situations. So it's become, really concerning to me that we as Black women are not, accessing healthcare right when we identify there may be something wrong. And then when we do, we're pushed to the side. So we're not getting the help, we're not getting the treatment and the services that we, we so need and desire. And it can lead to, death. So I really appreciate having this conversation with you both, because we need to talk to our sisters and talk to them about how we can better advocate for ourselves and also help them see the other side. So you were talking about your colleagues and that they need to do better. Have you heard anything about implicit bias? I know that's the buzz around,
Hey, Michelle, before we go through, I wanted to share again with my personal story as well on, in terms of how treatment with, and this isn't a story that I necessarily have shared before, but after I had COVID, I started to have symptoms where, I felt like my chest, I was having chest pains, right? And even though I'm not a doctor, I say I play one on TV, right? It was to the point where it kind of got to the point where I was kind of very concerned. I was actually out driving with my daughter, and it just kept getting worse and worse and worse. And so, at that point in time, I was like, okay, I'm having a heart attack. Like, my husband's a physician, but here I am about to have a heart attack. And, so, I call, and luckily for a lot of us, we have a network of friends that can, help us. And so I called actually Dr. Anise LeCount, who was close by, who we got on our panel earlier. And she said, you need to call 911. I was like, no, I'm just going to drive myself. You know, so we're just always kind of in denial, even though we're concerned. We kind of push it down. We push it down. And so, you know, I did call, I called 911. They came and picked me up like at the restaurant, and they checked me out. But, you know, I think sometimes we do fall under that strong Black woman, and we carry that amongst ourselves to the point where we're like, I'm fine, you know, I'm okay, you know, and so we're telling ourselves that because that's what we want. But also, you know, we're saying that to the people who are in a place to help us. And so since we're not, you know, crying, or we're not acting the way that other people act, a lot of times maybe they think that it's not serious. So I did end up going to the hospital. And even in the hospital, you know, it was like, okay, you know, walk over and go get this, you know, go get this x-ray, or go get this lab test, right? And it's like, I'm here because I think I'm having a heart attack. And so, you know, it's just like those kind of things. But I think a lot of times when you're there for yourself, it's harder to advocate for yourself because number one, you're in pain and you are afraid, you know, so you have that fear in terms of what's going on and how you should be treated. And in the moment when you're basically like mistreated, you essentially just want to get out of there, right? Like at least for me, I was like, just get me out of here. And if I have to go somewhere else and just, you know, deal with it, I'll deal with it, because the treatment wasn't what it should be. So, you know, I think that, you know, if a lot of us, if we were to share our stories, we would find that there is that commonality in terms of, you know, how we are treated, how members of our families treated. And as well as, you know, if you say, oh, I'm a, you know, my husband works here, or my, you know, the treatment may or may not be different. But again, at the basic points, that shouldn't be what is required, right? So, you know, I just definitely wanted to share that as well before we go on to the next question, Michelle. Thanks.
Can I just add one thing to that?
Yes.
Yeah, I think that one of the things that makes it even more sad is that we all have some experience in navigating that system. So we know, like you said, I know it was taking too long for this medication to come, because you're in that system. So, you know, this shouldn't take 2 hours. If you have no clue, you don't know what you're missing.
Right.
You don't even know what you're supposed to be advocating or asking for.
Right.
So one of the things that I try to get my patients to do is, you know, I tell them you should have a squad. It's just like when, you know, I'm not a plumber. If my toilet goes out, the plumber could come and he could say, I need $3,000 worth of, and I would be like, okay, where do I sign?
Right.
If I have a friend who is a plumber, even if he doesn't necessarily specialize in that particular aspect of the plumbing issue, he can tell me that guy's pulling your leg.
Yes.
Or let me look up, I have background. Let me see if what he's saying, maybe I can find a place we can get that part for cheap or something like that. And I think that's the squad or the network. So I try to tell patients, when you go to the doctor, you know, first of all, research what your problem is.
Right.
Try to find someone in your network, even an extended network, you can just run stuff by.
Yes.
It might be someone in your church who's, or someone, a friend of a friend. You know, say, I got this lab, you know, I don't really know what it means. Can you just take a look at that?
Absolutely.
And so that you know what you should be asking and how you can best advocate in that system.
Absolutely.
So it just gives you, and use your people. I mean, one thing that is good about the Black community is we know how to network.
Yes.
You know, we can, and that's an advantage that we have. We may not have a doctor in our immediate family, but we know somebody who's a nurse, or we know somebody who has an experience with that, or someone knows someone who is.
Right.
I think one of the limits that has been a problem is we don't like to tell people our business. And it limits us. You know, people get sick and so people die, and what do they die? I don't know. I just heard he got sick.
Right.
And it's like, illness is not a character flaw,
Mm,
you know, it's just, this is what it is. And if you reach
right.
out, someone might be able to help you. Someone might be able to be a connection. So I think that as part of this whole advocacy thing, we have to advocate for ourselves, number one.
Absolutely.
This is your health. After your relationship to your God, your health is more important than anything else. Family, spouse, kids, because if you don't have your health, you can't do the other well.
Absolutely. Absolutely. And we have a question in the chat from Carol Rogers, and she wants to know, is it the doctor or the medical groups that discourage referrals to medical specialists? And I know that's a generalized question, but I don't know if you guys are able to answer that.
It could be a mixture of both. So for a topic that we're discussing now, I have always had a PPO, because if you don't treat me how I want to be treated, or I don't think I'm going to someone else.
Right.
So it's challenging when you have an HMO. When you have an HMO, you have to have your primary who makes the referral. Your primary only makes the referral within a certain group or organization. And so there are limits there. So that could be a little bit challenging. And usually your primary then has to make a referral to the specialist. You might have to have 2 or 3 referrals from that primary before they allow you to go out of network.
Okay.
Well, by that time, the patient can be discouraged. So it can be that your physician only knows, your primary care provider only knows one particular specialist. And so they're making the referral to that specialist.
Right.
Or it's just that your healthcare group only allows you to go to this group of individuals, and they may not always meet your needs. And so it can be both. It could be one or the other. And so that's when you have to be very knowledgeable about your plan, what
Yes.
you're getting. It's not always about, I pay the lowest deductible, or I pay this is my monthly bill. You really should pay attention to your plan of what are the pros and the cons. And sometimes a plan works well for certain ages or time periods of your life, where a different plan probably will work better when you get to another stage of life.
Right. And we have a comment from Terry Parks, who says people treat their cars better than they do their medical and mental health. And so, also we were just talking about, sometimes we're easily discouraged, right? And sometimes when you get that discouragement, you use that as an excuse, right? Oh, I'm fine anyway, right? But if you're like, in terms of like with the car, right? When you keep hearing that sound in the car, you're going to get it taken care of, because you know that it could affect the car in many ways differently. So we definitely need to our health. And like you said, Lori, that should be the second, right, to our relationship with God. Like that is, we are, our bodies, we have to take care of it, because we only get one. And if we don't take care of it, that's it. Okay, Michelle, I'm sorry, your next question.
No, this is great. So I wanted us to talk about implicit bias, because I know that, that's kind of the buzzword, one of the buzzwords in, in the healthcare space. And I think there needs to be a lot of education. And one is acknowledging that we all have implicit biases. And a lot of the providers that we see, because most of us aren't fortunate to be able to see someone that looks like us. So, our provider may have an implicit bias. How do you, what do you say to individuals that, like I said, don't have a provider that looks like them? How do you engage in a conversation with someone to say, I want to have a partnership with you because my health is important to me, and I need you to see me and hear me. When I tell you something's wrong, I know my body. Please listen. So what would you advise?
So for me, I think, I was kind of trying to read a lot of things about this, and even asking my patients some questions this week when I knew we were going to do this talk. And there is bias in the system that we can't really control. I think there's a background of there are social injustice, that study that you mentioned that talked about pain perceptions, where they asked medical students and residents what they thought a Black person's level of pain was and how they always underestimated it or didn't quite believe it. That even extended to children. Children were not getting the same treatment for appendicitis. And that goes all the way back to slavery.
Right.
Where they actually thought or wanted to think that Black people were less sensitive to pain because then they could justify their inhumane treatment.
Absolutely.
And not feel as guilty.
Yes.
So I can beat you half to death if I don't think you feel that pain, and I can stay Christian and everything else and be justified in my mind. And that has persisted.
Yes.
So we know that these things are there. And while we should fight for that and, be in community groups and try to get, vote for the right people and all of that, so those things are changing, I'd rather focus with my patients on what can I do right now? Like, I have diabetes today. That's great that, I need my community needs more healthcare access and everything. But right now I have diabetes today. So what can I do?
Right.
And the best thing that you can do, that you can take control of in your hands, is preparing for your medical office visit like you're going to take a test.
Okay. And so what prevents that?
When you do that, that means, if I have this example of Miss Jackson is going to get her physical. She has 30 minutes in this physical. This is a problem with the system. It's horrible. It's crazy. The doctor has 30 minutes to see the patient, do an exam, get the vitals, do the physical, talk to them about their labs that came back, and treat them like a human.
Right, in 30 minutes.
In 30 minutes. So by the time you room the patient, by the time the patient gets their vitals done, by the time you look at the labs, you probably have about 8 minutes.
Wow.
See that patient and talk and have a discussion. That's not enough time. That's a fact. That's not enough time. So we know this going in. So since you know that, you should do whatever you can to optimize your time. How do you want to spend your 8 minutes? Do you want to come to your appointment 15 minutes late? Because if you do, that's your health.
Yeah.
It's not the doctor. That's your health. So if you're now 15 minutes late, then maybe the doctor has 4 minutes. They see you once a year. Something is going to get missed.
Yeah.
That you cannot do it in 4 minutes. But if Miss Jackson comes to the doctor 30 minutes before her appointment, fills out the extra paperwork that she didn't know she was going to have to do, she maybe has her sister or her husband or someone with her who can take notes and talk. The lab work was done before the appointment, so she got the labs herself. She looked up, what is this? Oh, this TSH is low. What is a TSH? I'm going to Google that. So that when I get to the doctor, I have found out that TSH is thyroid. Why is my thyroid low, doctor? What do you do for that? So she has her list of questions. So she is in control. She's guiding the doctor. The doctor is telling her, but it's not like she's just sitting there in the principal's office.
Right.
And I will tell you that when the patient takes an interest in their own health, it makes the doctor work better. Because now it is a collaboration. Now we're having a discussion about how we're going to do this together. And so as far as bias, back to your question of bias, it is there. You're not going to change the bias in your office visit appointment. We need to change that systemically, yes. But for you right now, with this new diagnosis of whatever it is, what can you do? One thing you can do is be as informed as you can be so that you can have a fruitful office visit appointment.
So
You're
Lori,
not going to learn everything in that 8 minutes,
Yeah.
but you can do the best. Ask the doctor, hey, I know you don't have enough time. What websites would you say I should go to look into this? Do you have any online support groups? Do you have any other recommendations that you may recommend that I can learn more about this? Can I email you if I don't understand something?
So
So
Lori, it sounds like you're basically saying that it's a partnership, right?
it is
And so if you're
definitely
going into something as a partnership, it is not like I'm going and you're doing all the work, you know, physician or doctor, whether you have a bias or not,
and
right?
you have to be aggressive. If
Okay.
the doctor orders a lab, don't wait till the doctor calls you with the lab result. You find out what the lab result is. And if they don't call you, you know, because things get lost.
Yeah.
You know, I had a patient one time. The doctor was really busy. She was supposed to get her slip for her mammogram. She didn't get it. She said, "Oh, I'll see her next year." She had cancer the next year.
Wow.
And it was the doctor. Doctor should have called, you know, have remembered to give her the mammogram slip. But I'm also like, but that's your life.
Right.
So if they slip, what are you doing? You know you need it. You know what your screening tests are. So you got to do your part too, so that everybody's working together.
Yeah.
I
Michelle, we have a comment from Sue Ann McCormick in the chat, and so I wanted to see if maybe Nalo could respond to this. Racial bias with regard to pain assessment is a major issue. Many of her Caucasian friends seem to easily access all kind of pain meds, yet her daughter, who suffers from chronic pain, is treated with so much skepticism. How would you respond to that comment? And Lori, feel free to jump in on that as well.
So, very true. Usually, providers will respond to people when you express the fact that you have pain. So sometimes when we're talking about bias, sometimes we go in there saying they don't listen to me anyway. So you're going to this, but you're already coming with they're not going to listen to me. You need to come in, and I say practice, actually. You're going to listen to me. So you have that. The other thing is if you have a child, there's always a situation with what is the age of that child. So when you say I have a daughter who has that, question becomes
she's in the late
20s,
Yeah.
then it's one of those things that you're gonna have to advocate for. This is what I have, this is what I've done, this is how long I've experienced it, this is where it doesn't change, this is what helps it goes better. And I think Lori mentioned that there are ways that you can communicate with your provider, not on just the day of your visit. You can call and talk to the nurse who's on duty. You can actually go into the patient portal as soon as you feel it, and you start blowing up that patient portal. We have to answer that thing. You can make sure that before you get there, you're ahead the day before. I'm coming in. I've done this. I've done this. I've done this. Then there's a patient services line that you can call. And I'm in one of those practices that they call you after hours. I'm still having this. So when we're talking about advocating for yourself, it is using all of these resources. What we could say with the Caucasian friends who have all these resources is they've done all of that. They have called the nurse. They have called every 30, 45 minutes, depending on how bad the pain was, 3 days before they showed up. We are tired of Miss So-and-so calling. Please, just send a script for this. Give her a walk-in visit. Matter of fact, tell her to go to the urgent care. We'll call them ahead of time so she can get into the urgent care and move. When you're, I am answering this in general because I don't know what this young lady has done.
Yes. Well,
so when you're doing those things, it's unfortunate sometimes, but the saying actually works. The squeaky wheel gets the oil. Yeah. If you are in that pain, your doctor has to respond to what you put on the patient portal. We get dinged for that. They have to respond to that phone call. You call, they don't call you back. Guess what? You put them on speed dial and you keep calling. I called it this time. You call 3 times, they don't answer, you go to patient care services and start saying, I have called on this, this, and this, and document it. The other option you have is usually we have walk-in visit spaces.
Yeah.
You ask, when's your next walk-in visit available? They say we don't have one. You take your happy hips to the urgent care.
Yeah.
Because if you're in that network, the other thing they look at is how many times does a patient that we have on our panel access urgent care when you should have saw them in
right.
So those are things. The other thing I would also like to recommend is you have to document what is it that you have done or taken. So when you get in and you said, I'm having this pain, and I'm going to say, generalize if it's a young lady, I'm having abdominal pain. So when I ask you, what have you done? And you said, well, I've just used a heating pad. What it lets me know is, okay, well, I'm going to start with the most basic thing. Let's find out when your last menstrual period, what it was. And I'm going to give you, have you tried over-the-counter naproxen? Have you tried over-the-counter ibuprofen? If you say no, it's likely I'm going to start there because I'm going to start low first and then take it up after I find out what things haven't worked for you. So I would tell to that young lady is you need to document when you go in for that visit, that phone call, that portal entry. I have done this for this long. How many times? I have taken Advil. Well, what was the dose? I don't know. It was over the counter. Okay, well, how many pills? You need to know that because if you've done these things, so we always start low and then we move up. Then I have a better idea when you come in on that visit to say, oh no, we're not going to start with ibuprofen 400. Let me see what's going on. I'll draw some labs. Might need to do some imaging. I might start with 600, change the frequency. And then that also allows me to tell you when to come back sooner. But if, in a sense, as Lori said, you have to take a squad with you. We need documentation so that we know where you started, because what we don't like to hear, but I have heard this. After you left your appointment, you called patient services and you said they gave me ibuprofen 400 milligrams, and I already did that already. Then they go and look at my chart to see if I did it, because when they look at patient services, they then come back to my chart. If they don't see it documented there, and I have said, ask patient about pain management, what they did, documented, only using heating pad, no medications taken. Then we have a disconnect, and then it's hard for us to now collaborate, because now patient services, believe it or not, is going to send me a little flag and say, we saw this, they called for this, you need to follow up.
Okay.
So to that question, I know that's a long answer, but to have that relationship, the patient needs to document what is it they have done and use all your resources, because you can get attention from me without coming into the office. So use them.
Lori, did you have anything you wanted to add to that?
I would just say that, the ironic thing is that is definitely true that Caucasian pain was taken more or believed more than African American or any minority group. And the ironic thing is that in this whole opiate crisis,
right,
there was an overprescription for white people and an underprescription for Black people. So when that whole crisis really started to just ramp up, it was, white suburban moms who have a little bit of pain and maybe Tylenol would have sufficed, and they got oxycodone. Whereas the Black person was in the ER with a fracture and they got Tylenol.
Right.
So in a not good, but in a kind of good way, we didn't see that pill crisis in the Black community as much as we did in the white community. The ironic thing is that's why it got all of the attention. It was because it was affecting them.
Right.
But so as far as, if I don't, without knowing that person's particular story, I would just say, just in general, if you find that you're not getting the service that you think you need, you should get a second opinion.
Absolutely.
You always have the right to get a second opinion. That's without knowing this, because opiates, it's a whole thing. So without knowing everything, that's probably the only thing I could really say. But if you feel like you're not getting treated appropriately, that's as far as racial issues. I mean, we know that has been the case, particularly with pain. There are studies. So.
Okay, fantastic. Michelle, sorry, your next question.
No, that's okay. So how do we change that narrative? We've all talked about creating a partnership with your provider. Like, let's back up. Let's pretend like none of us have any healthcare experience. We're just a regular young Black woman trying to navigate her way through the healthcare system. I encounter my provider that was assigned to me, and they seem a little aloof, maybe a little cold. I can assume there's racial biases, but I'm not going to do that. And how do I engage them? How do I help them understand I want to create a partnership? Because sometimes you get that glazed over look, like they've already figured out who you are. How do you break that down and still advocate for yourself? What are things that someone can say that they can do to say, I want to have a partnership with you. My health is important to me, and I want to be able to come to you and talk to you, and have you help me, right? Make sure that I stay healthy.
That was perfect. I want to have a partnership with you about my health. That is what you lead with. Sometimes in certain circles, you call it your elevator speech. You come in with your elevator speech to your provider, and you say that I want to have a partnership with you. I want us to be able to work with my health. I have concerns about my health, and we both need to be engaged. Something similar to that. You lead with that. First of all, we're gonna be like, what? How's it coming in? And it just changed, because you're right. When you say we have a glazed look, depending on how big that panel is for that day, what time you come in for the day, who did we see in the room before we came in to see you, we may not realize we're actually giving you a glazed look. We want to be engaged, but we're still frustrated 2 rooms back at the person I still have to go back to see because they were yelling, or they have a laceration. I got a suture and there's blood everywhere, and somebody better clean that up before I get in there. I may not be fully present when I'm in the room with you. So that elevator speech is going to bring me present in the room. And I have an uncle who, when I was little, he was my physician. And so it was kind of interesting going out and seeing him, and then seeing him in other places, and then having my appointments. And one thing I learned from him is, at the end of the visit, he would talk to me and he would say, "Are you done? Is there anything else we need to talk about?" And I've taken that into what I do, is that always take that pause before I leave out of the room, because I know, as Lori has said, your 30-minute, 8-minute, 10 minutes of fame is as long as I'm in that room. As long as I'm in that room, it is all about you. Make it count. Because once that door cracks and I step out, it's every man for himself. Or every woman for themselves. Because then you might have your medical assistant, your nurse who's talking to you. You got to go back to the other room that you were leaving in. So it's important, as you say, you lead with that elevator speech. It's like, okay, how do you have that? If you notice that your provider doesn't sit down, you could ask them, could you please sit so we can talk? If you notice that your providers, because they act like we're supposed to be more efficient when we're charting in the room with you. If you notice that you actually need the eye contact, you can actually ask and say, could you please stop typing and talk with me? Because if you don't, we're assuming you're cool with it. We're like, yeah, we're gonna get this, and we're going. And you're like, I don't, this doesn't feel collaborative. So you can ask for those things. I think when we talked a little bit about the biases over, there is actually a structure. It's called the Superwoman schema, in which Black women do not advocate for themselves, and that schema has highlighted areas in which we don't. And
Right.
so many times we have to actually look at our own role, going back to the elevator speech,
Yes.
and coming into the room. It's not, I want you to tell me, it is now collaboration. And so we have to break out of that space of, in a sense, maybe in the back of our head, assuming that we don't matter enough for them to slow down, whomever the provider, whether it's a male or female provider, whether it's a Black or white provider. I don't think, no, I'm coming to you so that we can collaborate, because I am excited about my health. I have some concerns about my health. You leave with that elevator speech, we slow down.
Lori, did you want to add anything to that?
I anticipated this question, so I wrote some notes.
Okay, great.
So I think the best thing to do is prepare. And I saw a quote, and they were saying that the office visit with the doctor starts before you even get to the office.
Mm-hmm.
You have to do your homework. So some of the things you can do, figure out what, if you know you have a medical problem, research the doctors. Who do you want to establish care with? Maybe it's a primary doctor who has, done some studies in high blood pressure. Like, oh, I have high blood pressure. Maybe I'll pick him because I know that's a thing that I have.
Right.
So that I'll pick that doctor. So research the doctors. Once you establish care, come prepared. Have a list of your meds. Please have a list of your meds. Don't say it's the blue pill, it's the red pill. I don't know what the blue and the red pill is. I just write the prescription. I don't know what color they are. Know why you're taking the medicine you're taking in layman's terms. I take this because I have high sugar. Know how to judge if the medicine you're taking is working. What are the parameters? If they give you a pill, ask the doctor, well, you're giving me this for my sugar. How am I going to tell if it's working?
Right.
If I'm taking a blood pressure medicine, do I have a blood pressure cuff at home? How do I even know if it's working? Maybe it's too low.
Right.
If it's too low, if it's not working, can I call you? Or do I wait another year for my next physical? And then you're like, hey, this isn't working. Like, it hasn't been working all year.
Right.
Or if I have side effects and I just stop it. Like, you still have high blood pressure. You got to take something. So you have to do your research before. You have to come prepared. And like I said, that is going to make the doctor realize, oh, this person, I got to make sure when they come to their appointment, I've checked my stuff. It makes me think of, this is kind of off, but sort of related. I always tell patients, when you're in the hospital,
Okay.
you have a loved one in the hospital, you have to have family member go.
Yes, absolutely. Yes.
And I will tell you why. I can remember, I don't do inpatient stuff anymore, but I remember when I would do rounds as a resident, if I had 20 patients to round on,
Yeah.
the patient whose family member was going to be there, they got their labs checked first.
Yeah.
Because I knew, and it's not that I'm putting the other person there, everybody's important, but Mrs. Jones's sister is going to be here at 10 o'clock. So I better make sure I got those labs done, talked to the nurse, looked at the patient, did the exam. So, because she's going to ask me questions. That puts you in priority. So I don't even know how I got off on that tangent, but it made me think of just being prepared and how you can best utilize the time that you have in the appointment so that you are going to get treated appropriately.
Right.
And efficiently.
Right. And so, and there's a comment in the chat about trust, right? And in terms of the provider being able to be trusted by, the person that is coming to see them. I would assume that trust kind of has to be both ways, and we're still talking about that partnership. But again, a lot of people are coming to the physician or to the doctor's office, especially as Blacks, in most instances, when there is a problem, right? It's a problem you can't ignore anymore. The car is clicking, the tire has a flat, all those kind of things. Unfortunately, a lot of times when we come, it's sometimes a little later than normal. And so we are very vulnerable in those moments. How do you all build the trust and the relationship with your patients, if you're able to kind of share that a little bit?
It takes 3 seconds for a patient to decide whether they're going to like you or not.
Okay.
As soon as they see you, they make a snap judgment.
Okay.
And from that time, and I even tell my students this, I said, how long do you think it's going to take for you to create a trusting, collaborative relationship with your patient when you walk through the door? Some are like, a couple of visits. And I'm like, you done lost them. They didn't show up for their second visit. They saw you the first time. They didn't do that. From the time you walk through the door, they're making judgments, and you're working on those judgments. Many times, in order to navigate that, especially like I said, we don't always look our age when we walk into the room. I can. Lori talks about how they're like, so when's the doctor coming in? I mean, I'm walking, and they're like, I even remember walking into my classroom, and one of the students was like, okay, so the professor's not here on time. And I'm looking at him like, I've been here. So, those are the judgments. And so you're working on those, you're peeling them back. Honestly, when you're coming in at a point of vulnerability, your patient has already seen you come through the door. You're not building, you're building, but you're also taking away at the same time. And so it's a two-way street in a sense, because as a provider, I'm trying to anticipate or feel the room. And at times I do it better than others. Am I present? But at the same time, the patient is trying to figure out, okay, are they listening? Are they not listening? How are we going to do? And so sometimes it requires me, when I'm building trust, is to say, you look uncomfortable. I move completely off. You look uncomfortable. Maybe we should sit in the chair while we do this interview before I have you sit onto the exam table. Breaks it right there. Or, you know what? I like those fingernails. Sorry, that was a squirrel. So what brings you here today? Oh, I like those tennis shoes. Well, oh, sorry. Because it interjects a little bit humanity. But then I have those patients who come with an attitude, and it's just like, oh no, I got to change vernacular. That builds trust. So it kind of depends. Sometimes we're chameleons, and sometimes we come in like a hammer. I've already heard you talk to my medical assistant. I've already heard you talk to my nurse who roomed you. Guess what? We're going to start at the bad cop first. Then I'm going to move to a good cop. And depending on how it works, it does build trust, because sometimes when you're vulnerable, the patient's not nice because they're feeling that vulnerability. So they're creating whatever safety or normalcy they have. So it depends. It really does depend.
What about you, in terms of if you come in and have to build that trust, or you feel the bias in your patients as it relates to you being a young Black woman?
It's hard in 8 minutes.
Yeah.
It's hard. I mean, that's the thing, is it's an art. I don't know that I've mastered it, but it's hard to do everything, do the exam, listen to the patient, sing like a human, make sure you're not missing anything, and everybody's happy. It's hard. I think the one thing, and also I think Nala, you mentioned this yesterday, or somebody did, about how Black people don't trust doctors as a whole, and they've come by that fairly. Like that is a legit issue. We have a history of not being treated well and being treated as objects, or used for experiments or whatever. So their distrust is inherent. They walk in there and it's always like, what are you doing? Why are you doing that?
Right.
And they might not say that. And somebody was saying how, like, when white people go to the doctor, they will have, why are you doing this? You know, this is, I saw this, I had this paper, my friend did this. Why aren't you doing that?
Mm.
We should be more like that when it comes to our, though they have it correct. You know, you need to question the doctor. And so, as far as building trust, I think one way is when you have an issue, you do your homework,
Yeah.
and then you have a conversation, and the doctor can interact with you on a working relationship level. This is like a business meeting, you know, and when they can respond to your needs or to your questions appropriately, then it goes back to this collaboration. I think that it's a relationship, and it takes time. It's over years. You know, if it's your primary care doctor, it might take. This is one thing I tell patients: you should establish care with your primary care doctor when you're 20, 30, before you have an illness.
Hmm.
So that you have this relationship, so that you know, like, yes,
Yeah.
this is the doctor. I know, yeah, we have this relationship. I know. So now when something happens, I'm not trying to figure this all out in my 8 minutes
Yeah.
at one time.
Yeah.
You know, so that building trust when you're not in a crucial moment is important. When you're not under
Absolutely.
stress.
Absolutely. Well, wow, this conversation has gone like we got 3 minutes left, maybe two, right? And it's just, it was a very, very collaborative conversation, which I enjoyed thoroughly. So what we will do now is, we'll start with you, Nalo, in terms of a summary, and then we'll go around the room for that before we close this out.
I'm going to take the point of view is come with your elevator speech, your elevator speech of collaboration. You can never underestimate how important that is.
Fantastic. Okay, Lori?
I would say along those lines, collaboration, but the most important person in the encounter is you.
Yes.
So you have the most work to do. And you cannot let a bad encounter or one that you felt didn't meet your needs, you can't give up, because the only person who it's going to affect is you. So if you don't like a certain situation, change it, get a new doctor. If you didn't find the answer you wanted, find someone else, use your resources.
Yeah. Fantastic. And Michelle?
So I say, make your health a priority. Come prepared, maximize your moments. As Lori keeps saying, we have to make sure that we make those 8 minutes count and develop a partnership.
Absolutely. Well, I am going to say thank you all, for my panelists, for my co-hosts, for Nalo's exceptional brain that said we need to have this conversation. We need to break it up into small parts so that we can cater to a particular age group and a particular group. I want to thank Michelle for bringing it into like the invisible Black woman and how advocacy for the sake of our health is very important. I want to invite all of you to continue to follow and subscribe to Healthy Heart Nation, our YouTube channel. This is our Heart to Heart series. All three of these beautiful women, beautiful, smart, talented, exceptional, passionate, blah, 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 all those things, women are Healthy Heart Nation ambassadors. And so please look for myhhn.org so that you can learn more about the things that we're going to be doing every month. We're having a heart-to-heart conversation every third Friday of every month. Please, again, like and subscribe to the videos. Please share it. And please continue to be a part of our community, because with that, we can change the nation. Thank you and have a great night.
Good night.
Thank you.
Bye.